Morning, everyone. So I'm Lisa Bailey. I'll be your moderator for the next 3 days. I am Specialist Communications for Health Promotion in the PAHO Caribbean office. I know a lot of you from working across the region for maybe 2 years or so, but some of you from Barbados because I worked quite closely with the Ministry of Health as an officer for the Government Information Service. So I know where you're coming from in terms of communicating information and working with the ministries and getting information to the public. So today we are here for communication and vaccine. It's a long title. It's because we have a lot to discuss. Communication and vaccine demand generation workshop with a focus on equity, gender, and cultural diversity. That latter part, we're going to do that on the last day. We're going to be talking a lot about that in the last day. We're going to get started with remarks from my boss, Mr. Dean Chambliss. He is Sub-Regional Program Director for the Caribbean of the Pan American Health Organization, World Health Organization. Please make him feel welcome as he comes.
All right. Good morning, everyone. Thank you so much, Lisa, for that very kind introduction. And I was just speaking with my colleague, Dr. Broom. I think this is the first time that this network has met face-to-face in, what, 3 years? It has been a good long time. And I know some of you are new. Probably you've never had a chance to sit face-to-face. So I think this is a great opportunity. I think it's symbolic of the emergence of the Caribbean sub-region from the COVID crisis that has gone on for such a long time. Last time I was in meetings here in the Hilton, they were all outside because we had to maintain the distance, etc. So it's certainly a new day here. So with that, I'm just going to make some brief opening remarks, and I'll start by welcoming all of the distinguished guests here today, communications officers, EPI managers, PAHO colleagues, and ladies and gentlemen. On behalf of the PAHO Caribbean Subregional Program, it is my pleasure to welcome you to this highly anticipated training on communication and vaccine demand generation, with a focus on equity, gender, and cultural diversity. The Caribbean has a long and respected history of leading the world in the elimination of childhood diseases that are preventable by vaccination. This subregion was the first to eliminate poliomyelitis, measles, rubella, congenital rubella syndrome, diphtheria, and neonatal tetanus through vaccination. We have sustained the elimination of these communicable diseases for decades. The success of the expanded program on immunization, or EPI, was due to the commitment of EPI managers and National Immunization Program staff, unwavering political and technical support, and recognition by the public that vaccines prevent disease and death. The provision of technical support and guidance by PAHO to strengthen national immunization programs, along with strategic funding, also enabled countries in the Caribbean to maintain high childhood immunization coverage and achieve historic immunization goals in the region. Unfortunately, the introduction of the COVID-19 vaccine in the Caribbean has been faced with a myriad of challenges, which include, but are not limited to, insufficient human resources, the initial slow delivery of vaccines, which was unable to satisfy early adopter demands, a lack of trust among some segments of the population in the vaccine itself and in vaccine-related recommendations, a lack of an adult immunization platform within EPI programs to manage adult vaccination, and ineffective communication to combat misinformation. These challenges have led to many Caribbean countries being unable to meet the 70% target set by WHO in October 2021 for COVID-19 vaccination. In fact, some of our countries are still struggling to reach 40% coverage. As the pandemic evolved, there was ample evidence of the effectiveness of COVID-19 vaccines to reduce the risk of severe disease, hospitalization, and death. However, the vaccine does not prevent transmission, and a delay in getting more people vaccinated in the height of the pandemic resulted in a proliferation of variants of concern. We recognized quickly that we needed to ensure high COVID-19 vaccine coverage in groups that are most vulnerable to severe outcomes. These include the elderly, those who are immunocompromised, and people living with chronic diseases. PAHO therefore urged countries to increase efforts to ensure that these vulnerable populations are protected through vaccination. The COVID-19 pandemic revealed gaps in our capacity, programs, and human resources. In addition, We recognize the weakness in the rollout of risk communication and community engagement activities. To address these challenges, this workshop is designed to 1, provide the tools and skills necessary to develop and implement activities to increase vaccine demand. 2, expand risk communication and community engagement. 3, bolster infodemic management techniques to improve vaccine acceptance and uptake. And 4, build capacity to develop communication strategies and materials that are culturally and gender adapted, non-biased, and targeted to specific vulnerable population groups. Misinformation about COVID-19 vaccines is a serious threat, not only to public health, but also to national economic security. The pandemic has undoubtedly been financially devastating to small island state economies, resulting in the loss of lives and livelihoods across the Caribbean. Recently, the traditionally high immunization coverage in the Caribbean has been on the decline, even for routine vaccinations. This has been exacerbated by the COVID-19 pandemic. The use of EPI program resources, human, equipment, and financial, to manage and control COVID-19 cases and to deploy and administer COVID-19 vaccines has compromised some national immunization programs. The recovery of these programs has been slow and fraught with challenges. Declining childhood immunization coverage, along with increasing numbers of visitors from across the globe, can easily lead to a reintroduction of previously eliminated childhood diseases like the very infectious and potentially dangerous measles. Improving vaccine demand through community engagement and targeted communication will not only enable improvements in COVID-19 vaccine coverage, but can improve immunization throughout the life course. The skills and knowledge you will be exposed to over the next 3 days can bolster national immunization programs in this region. We have been administering COVID-19 vaccines since the beginning of 2021, and we expect that COVID will continue to be part of the global disease landscape for the foreseeable future. Considering this, PAHO will continue to support countries in the integration of COVID-19 vaccines into routine vaccination programs and strengthen EPI programs that incorporate vaccines throughout the life course. I would like to acknowledge the governments of the United States, Canada, and Germany, whose generous donations have enabled us to fund this and many other opportunities for immunization program strengthening and human resource capacity building. Please take advantage of the presence of the PAHO team this week. Ask questions, raise your concerns, and make the most of this opportunity. Undoubtedly, we can also learn from you. So once again, welcome to this training workshop. We hope that at the end, you'll return to your countries reinvigorated and enthusiastic about putting all that you have learned into practice. I wish you all a successful week and the very best in your efforts in your national immunization programs. We simply cannot do this without you. Thank you very much.
Thank you very much, Mr. Chambliss. So now it's time for us to get to know each other a bit. They put me in charge of the icebreaker, so you know we're going to have some fun. I went home and I did a Google. They used to call me Google It at my former workplace. So we're going to get to know each other a little bit. And PAHO team, you're a part of this icebreaker as well, okay? So we are going to get to know each other by each of you participants, kind of considering yourselves on this map here of the Caribbean, right? Each of you is going to stand up, tell me your name, where you come from, where you grew up. It may not be what you're representing today, but where you grew up, and a value you got from that place and why it's so important to you. So we'll get to know a little bit more about you. So where you're from, where you grew up, and a little bit about what values you got from being in that place. Yes? So I'm going to start. So I'm Lisa Bailey. You know I'm PAHO Caribbean. I am truly a Caribbean girl, born and bred here in Barbados. And I think my main value is hard work. Pride in industry is in our slogan for the country, and it's definitely something that I came up with in my family. My father always used to say, can't get by on your good looks. You're gonna have to work hard for what you want, and that has definitely been something that I've continued to keep, important to me. I know I have to work hard, so I don't expect anything to come easily for me. Okay, so you get it? Just a short thing on you, tells you a little bit about me. I love to work hard. I'm from Barbados, and I'm from PAHO Caribbean. Maite has chosen where we're starting because I see she has the mic. So let's go. Let's go around the table. What country are we, where are we on the map?
My name is Tekis Vogel. I am from Jamaica. I work at the Ministry of Health and Wellness there. I am the Director of Health Promotion and Education in Jamaica. I come from, what would we call it? One of the rural parishes in Jamaica. So most people know Kingston, but it's a rural parish, and I believe the greatest value I would have gotten there is just a sense of community, everybody looking out for each other. Thank you very much.
Wonderful. Thank you. Next.
Boy, I was really hoping that the microphone wouldn't go around in this direction. Alas,
Nope.
here we are. Petra Williams Reno. I too am from Jamaica. I'm the manager of public relations and communications, also at the Ministry of Health and Wellness. I also am from a little parish called Trelawney, famous because of Usain Bolt.
Whoop, whoop.
Whoop whoop, yeah, right?
Sorry. Yes.
Actually, so. And I think one of the values is just to, to respect yourself and to respect others. And I find that where there is mutual respect between people, things go very well.
Thank you. And you don't have to stand if you don't want to. If you want to stand, you can.
Good morning, everyone. My name is Lilia Middleton. I'm the EPI manager for Belize, and I work at the Ministry of Health and Wellness. I born and grew up in a village, we call it a village, in Esperanza, and the meaning of that village is hope. So what we have learned from that is that with hope and with belief and with hard work, we can do anything. Thank you.
Good morning, everyone. My name is Kathleen Aswetacho. I'm the technical advisor for the Health Education and Community Participation Bureau at the Ministry of Health and Wellness in Belize. I grew up from Belize City, and it's a south side area. So we grew up we call it the rough neighborhood of Belize City. And I think one of the greatest things I learned from that household was discipline, and bringing that discipline, self-discipline in every aspect of your life. And one of that is in the workplace setting. So thank you, and glad to be here with everyone.
Thank you.
Good morning, everyone. My name is Yosifia Williams. I am from Bermuda. I am the public health educator for the Health Promotion and Wellness Office. I was actually born and raised in Dimona, Israel, in a small Hebrew Israelite community. So one of the main values that I got and what's motivated me to be in health, and that is kind of everlasting life, and that's to kind of access those things when it comes to health the best you can, and live, life on earth the best we can.
Good morning, everyone. My name is Janor Smith-Kelman, and I am the Communications Officer at the Ministry of Health in Antigua and Barbuda. And I would say that I have learned that together we could do anything, work as a community, work in unity with respect, and everything else that everybody said at the table, coming together as one.
The PAHO table is not getting out of this. I see what you did there, my dear. Okay, go ahead.
Good morning, everyone. I have to start with a disclaimer. I am Unika Scott, the MCH officer, Maternal and Child Health Officer from Guyana. And my disclaimer is we're not on your Caribbean map.
Ooh.
We're actually a South American country with deep Caribbean ancestry. We like to make that clear from time to time.
Gotcha.
We are the only English-speaking country in South America. And one of the values that we have taken away as a country is to appreciate deeply other cultures. If you know anything about Guyana, we are a nation of 6 races. So if you look at me, the color of my skin doesn't say that I am Black, because my great-grandmother was East Indian and my great-great-grandfather was Amerindian. And so there is no real Black or Indian in Guyana, despite of how we look. And that has really led our charge not to see race, but to appreciate culture. That's my takeaway.
Lovely, thank you.
Good morning, everyone. My name is Shabana Shah, and I am the Acting Head of Public Relations and Health Promotion at the Ministry of Health in Guyana. I know Dr. Scott just represented us very well, but I'm just gonna say I was born and raised in a small island in the Essequibo River called Leg One, and having to grow up there, you know, and having very minimal to live with, and that includes not having electricity for most of my life. As a teenager, it has taught me to stay humble. Regardless of your status, wherever you go in life, stay humble. Thanks.
Thank you.
Good morning to all. I am Sabrina Bernard from the Nature Isle of Dominica. Yes, from the community, or we call it the village of Kalibishi. But what I will speak to is community orientation and family support. And this is what you can take to the workplace. Having the support of your colleagues at the workplace can also make the workplace more productive, and then you have a stronger team to work with.
Thank you.
Good morning, everyone. My name is Yvonette Anatole Carbon from the lovely nature island of the Caribbean, Dominica. I always say we are the only place where you can have 365 rivers, one for every day of the year. I always boast of that. So I work with the Ministry of Health as the acting EPI manager. I grew up in a small community, a farming community, where we were taught you have to work hard. Do not depend on anybody for anything, so you have to work hard for whatever you want. And whatever we had, we shared with each other. So if you planted yams and I had bananas, at the time of harvest, we all shared. So that is one of the things I loved about it.
Wonderful. Thank you. Next person.
Okay, good morning, everyone. I am Penny Maloney. I am originally from here, Barbados, but I am here today representing Montserrat, where I am the health promotion coordinator. And what has Barbados taught me? Like you, pride and industry, that was very important to me growing up. And I think it also taught me the value of making the most out of the opportunities that you're given, because I am the daughter of immigrants who came to Barbados looking for a better life. And you know, you had to struggle, you had to work. I saw my parents doing it to get what they have. So that certainly, you know, is ingrained in me that you have to grasp the opportunities when they come and not let them pass you by.
Thank you.
Good morning, everyone. I am Therese Burrell Prihe. I am the head of health promotions and communications for the Public Health Department. A special shout out to my Jamaican colleagues. I am also Jamaican. I was born in the parish of Clarendon, and what I have learned, or what I carry with me throughout my professional life, is our motto in Jamaica, out of many, one people. Ironically, I also was raised in the UK, and I was exposed to diversity there as well. Thank you.
Thank you.
Good morning, everyone. I'm Joanna Rose Wright. I was born and bred in Jamaica. Yes. And one of the things that we heard every day in our community is manners take you around the world. It has taught me to be very respectful to myself and to others. Today, I represent the Cayman Islands. I live in the Cayman Islands. I work as nurse manager for primary healthcare services, and I am representing the EPI program here.
Thank you very much.
Hi, good morning, everyone. I'm Lisa Johnson from the Accent. I'm from here, Barbados. I work in the health promotion unit, and one thing I have learned from growing up at church is the golden rule: do unto others as you would have them do unto you.
Thank you.
Good morning, everyone. I'm Donna Barker, Senior Health Promotion Officer here in Barbados. Growing up, I lived many parts of Barbados. I didn't grow up in one area. I was born in St. James near the beach and moved central, then south, then central again to the country, where I think I spent most of my years in the country. And now at this stage in my life, I am back by the coast again, by the sea. what I learned growing up, because we moved around so much, and also in addition to that, my parents had friends from all over the world. I learned to appreciate and respect people from all different cultures, different places in the world, and to get along with others and learn from them as well.
Thank you, Donna.
Good morning, everyone. My name is Lerone Highland. I am the Deputy Chief Public Health Nurse in the Ministry of Health and Wellness, Barbados. I grew up in rural Barbados in Christchurch, and those were days of hard work where children had chores. I had a sheep, so I had to learn that when my sheep ran, I had to run behind it. So you were into physical activity, climbing trees. All those are part of my lifestyle from very young. And I grew up in a very close-knit community. My mom's house was here, and Granny's was next door. And Granny was the matriarch of the family. And one of the things that she always said to us, if you don't work out, you would rest out. So she taught the value of hard work, and she was ahead of her time. So here I am at whatever age I am now and still trying to work out. Went to the gym last night.
Very good.
The second thing that she would have taught us is that respect due to the dog. And that meant that you respect yourself and you respect everybody, whatever their station in life. And these are things that have really served me well throughout my lifetime. Thank you very much.
Thank you, Lerone.
Good morning. My name is Natasha Lloyd Felix from St. Lucia. I serve as the Director of Health Promotion, Health Education. And for me, I grew up in a very small neighborhood, very tightly knit neighborhood, where we were taught that everybody looked out for each other. So whether your parent wasn't around, whoever else's parent was there, you deferred to whatever guidance they gave you. You were told to respect, and you were also taught to support each other. So for that, I've learned that support goes a long way. In the absence of what you know to be your support networks, there are others that you rely on and you work with. And that I've carried into my workplace in terms of support to others in whatever we do.
Good day, I am Fennel Neptune from the island of St. Lucia. One of the value, I was raised in a close-knit community which also had a lot of farmers. And what we learned is the value of family and helping others, and always extending a hand and sharing, which is very important for us.
Yes, good morning, everyone. I am Almarie Coates. I am the Superintendent of Public Health Nurses for Antigua and Barbuda. I really wear two hats. I am the EPI manager also. And I'm here representing also Barbuda. So it's Antigua and Barbuda, where the beach is just the beginning. And like my colleague from Dominica, I can boast of 365 beaches. She has the rivers, we have beaches, 365. Okay. Well, I am really happy that I can make a difference in someone's life.
Good morning, everyone. I'm Violet Brown from Montserrat. I am the community nursing manager. See, I skipped out where from. I'm going to keep that for last. I'm the community nursing manager with the responsibility for EPI. I was born in Happy Hill, a village in Montserrat, and you can see I am going to make you all happy. I am quite jovial, and I kind of like to see people as happy as I am. Hard work has always been before me, and I've managed really and truly to work around it and work with it. But in all of it, I have survived hurricanes, volcano, and COVID. And so I will continue to work hard. Thank you.
Thank you.
Good morning. My name is Faye Cook Nurse. I'm from Barbados with the PAHO ECC office, and Barbados and ECC office, I should say. I would say a little bit about myself. I also grew up hearing that hard work is the way to go, keeping the faith, persevering, and being a positive influence on others. So I'm pleased to be here. I'm part of our session, and welcome all of you who travel from abroad.
Thank you, Faith.
My name is Faith Thomas Astafan. I'm in Anguilla, born and raised. In Anguilla, everybody's basically family. When I grew up, everybody knew everybody. So you learn early to respect everybody. Because if you say something wrong to somebody, by the time you get home, your family knows. So you had to watch your P's and Q's and be respectful at all times.
A pleasant good morning, everyone. My name is Jennifer Gums, and as the old people say, my neighbor Stringborn here. One of the things that I have valued is that when we grew up, we didn't have much, but free school meals and free education has taught me that when you're belly full, you can learn and you can go on to be somebody in life. So with it all, I give God thanks that He has been good to me.
Thank you so much. The lone male participant?
Yeah.
Yes.
The rose among the thorns.
You are the rose among the thorns, he
That's
says.
correct.
I understand.
Morning, my name is Kevin Frederick. I'm from Grenada Communications. I grew up in the best place in the world, Grenada. And the best place in Grenada is Guave. I am very, very, very proud to be from Guave because of all of the stigma that is associated with Guave. So when people like myself is a product of Guave, we feel like ambassadors. Really and truly, I'm saying that because I grew up in a single parent home, and it was not no easy thing to come through the ranks. And you had to work hard. You had to be respectful. But one thing that, as a Guave man, we always say to each other that no matter wherever you go, once you meet somebody from Guave or somebody from Grenada, you defend your own right down. And that's what I carry with me wherever I go. So I'm proud to be from Guave.
Good morning, everyone. I am Shanika John from St. Vincent and the Grenadines. I am the Chief Health Promotion Officer for the Health Promotion Unit. It's a pleasure to be here today. I am from the island that is referred to as Hairuna, Land of the Blessed. And I consider myself blessed because in my country, we really invest and fuel a lot of youth leadership. And so I think that's a privilege for me to be even in this particular position and working towards building my country.
Thank you, Shanika.
Good morning, everyone. My name is Julie Douglas Russell. I am from a small but beautiful country called St. Vincent and the Grenadines. My superheroes are my mother and father. I grew up in the rural area in St. Vincent. By profession, I am a nurse. By position, I am the senior nursing officer and the EPI manager. Thank you.
Thank you.
Good morning, everyone, and thank you for the opportunity to be here this morning. My name is Hannah St. Paul. I am from the beautiful island of Grenada. It is the Isle of Spice, and it's also known for 100,000 jab jab. And this is why maybe I like the color black, because we have one of the best carnival. So we invite you to come on over in August, all right? Currently, I am carrying the hat of the EPI manager for Grenada, recently returned to that position. I grew up in what we call the countryside of Grenada, the parish of St. Andrew. And St. Andrew is known for its agriculture, and it's also known for family. And because of that, I learned the reason why you should be committed and dedicated. And I think those values would have carried me through when I had the privilege of leading my Ministry of Health through this COVID-19 pandemic. And at Grenada, we boast, I think, of having one of the most successful results of the management of COVID-19. Thank you.
Thank you very much.
Good morning, everyone. So I am Karen Broom, the advisor immunization for the Caribbean sub-region at PAHO. And when Lisa first spoke, I remembered my mother saying to me all the time, the tail don't wag the dog. But I'm not going to speak about that here. I know that the Caribbean people know exactly what that is. But I think that something that the Prime Minister of Barbados says all the time, many hands make light work. And I see that in the Caribbean all the time. The solidarity, that if I don't have, I'm going to lend you. I have this, let's work together and do it. So I think that encompasses who we are in the Caribbean, that we are willing to help each other and we are willing to assist with the circumstances. Thank you.
Thank you, Karen.
All right, good morning again. Dean Chambliss, Sub-Regional Program Director again. So I'm one of the few people that you'll ever meet who was actually born and raised in Washington, D.C. Everyone comes to Washington or leaves Washington, but very few people actually come up there. But anyway, so I grew up there, and my mother spent 40 years in public service for the United States government. And I think one of the main values that she taught me was compassion and empathy. And this is something that has stood me well in my 30-year career with the United Nations as I move around the world and I meet many different people from many different places, and it helps me to listen and to hear them. Thank you.
Thank you, Dean.
Good morning, everyone. It's very nice to be for the first time in Barbados. My name is Tania Escamilla. I grew up in the city of Barranquilla, Colombia. Even though we're not considered officially, of course, a Caribbean country, I am from the Caribbean coast of Colombia, and actually being here in Barbados makes me feel like home in many ways. And one of the things that I learned growing up in Barranquilla, besides, of course, embracing diversity, because we're a very diverse city with people from many backgrounds and many migrants throughout our history, is also to appreciate, cultural nuances and the respect for everybody, every person's beliefs. And I think this is really key for the moment that we are on right now. And the topic that brings up to this workshop, of course, vaccine demand generation, how to understand other people's concerns without judging them. That's an important thing that I really learned from my family and growing up in a very diverse city. So thank you very much.
Thank you, Tanya.
Good morning, everyone. And it's really a pleasure to be here and to hear all of your experiences and where you come from. I think it gives us a great beginning to the workshop. My name is Maite Vera. I'm the Communications Officer for the Immunization Unit at the regional level. I was born and raised in Bolivia in South America. I, of course, now live in the US, but I think from living there and what my parents taught us throughout our childhood and raising us was just respect for everyone and also hard work. I know everyone has said that, but I think those are the two values that if your parents can give you that, it gives you a great foundation to go out into the world and really make something of yourself and understand that nothing will be given to you. You have to work for it. And yeah, that's just it. So thank you.
Thank you, Maite.
Good morning, everyone. I'm Solange Kobe Jackson, and I'm in charge of family health promotion during life course at the Barbados ECC office. And I know some of you virtually. It is a pleasure to meet you in person, and I think we can mingle and have to progress the work we started together. So listening to everybody, and I don't know what I should say because I have a long story. I was born in Africa, in the Democratic Republic of Congo, sorry. And I grew up in a large city, as you know, is the largest country in Africa, actually. And we are very populated, and we have 250 dialects, so we cannot understand each other easily. We have 4 official languages, but that's when I developed the sense of listening, because you might not speak the same language, you might have difficulty to communicate, but when you listen to the person, you look at his face, at gestures, we can understand each other. Mm-hmm. So I developed that diversity skills from a young age, and then working with the United Nations, I've been traveling around the world. I learn English. I'm a French speaker. I learn English, and here I am in the Caribbean. I will learn Creole or Bajan, right? I will learn that very soon, and I will be speaking to you in Bajan. Thank you.
Thank you, Solange.
Then let's go. Good morning, everyone. My name is Tatiana Santos. I work at the Office for Equity, Gender, and Cultural Diversity in PAHO. I am so happy that stay here with you these 3 days working this workshop, because the first thing is because I am the focal point for this region. It was my first opportunity to stay here in person with you. And it's a great opportunity for us as well to identify how we can improve our technical cooperation with these countries of this region. But also because I came from Brazil, I was born in a city named Salvador de Bahia that has many similarities with the Caribbean region. And I am feeling as I was my home. You don't understand how I'm feeling happy in this context of the Caribbean, because I saw the people, I see my relatives. When I see someone, when the people said me, good morning, when I crossing the walk, the people look at me as I was from here. And I am very nice, fine, and thank you very much for this welcome situation. I hope that you have a good work during these 3 days of the work. Thank you very much.
Thank you, Tatiana. Now, I forgot I have some colleagues on Zoom, so let's go to Zoom really quick. I'm going to go to Ave first.
Hi, can you hear
Ave?
me?
Yes, we
Can
can hear
me?
you.
Oh, wow. Good morning, everybody. It's great to be here. I'm happy to see everyone together and in person, and so happy to hear laughter and stories from around the Caribbean and outside of the Caribbean. My name is Avi LeBlanc. I work along with Lisa Bailey, and I work as an international consultant, IPC, with PAHO Sub-Regional Program. Great to meet everyone. Oh, I have to say what is important. Yes. What is some? Oh my gosh, I didn't even think about this. I could probably give you the quote that I really like, which is like, teach me and I'll understand, involve me, and I would, that quote that I don't have in front of me to read out right now, but that is something that I greatly believe in: participatory knowledge and participatory teaching and listening, and also acting together and co-creating value of health and social change programs. Great to meet everybody. Thank you.
Thanks. Ave is from Trinidad, but right now in Australia. So we really are representing the world today. Luisa?
Hi, how are you? Yes, my name is Luisa Solano. I am the communications technical officer for the Revolving Fund for Access to Vaccines. I am also from Colombia. I was born in Barranquilla too, like Tanya. And yeah, I think I could echo what Tanya just said. I think one of the things that we learn in a Caribbean city in Colombia is to understand a lot the different beliefs and yeah, the belief systems that we all have. Thank you for having me here.
Thank you, Luisa. Is that Elena? Can't see.
Hi, I'm Elaine. I really wasn't expecting this. I was like hearing everything. So hi, I'm Elaine en español. I'm from Dominican Republic. So yes, I'm from the Caribbean, but we are a Spanish-speaking country, and I'm really grateful to be here and listening to all of you. I work with Tanya Escamilla in the Health Emergency Department.
Thank you. Roberto?
Hi, good morning. Hello, everyone. Thank you, Lisa. Yes, so my name is Roberto Garza. I am part of Tatiana's team, the Office for Equity, Gender, and Cultural Diversity. We will be talking more about that on Thursday morning. So I am very grateful for the opportunity to join virtually and just following up with what all of you said. I'm originally from northern Mexico. And some of the most important values that my family has been teaching me since a young age is just to be thankful, grateful for whatever life has prepared for you one day at a time, you know. So thank you again, everyone, and as well, thank you for your patience and support through the logistics. It has been quite a very busy period for everyone. So thank you so much for your understanding, and I am so glad that many of you made it on site to this workshop in Barbados. Thank you.
Thank you, Roberto. I think that's everybody, correct? Is that everyone online?
Yeah.
Yes? Okay, good. Okay, I'm just going to show you the agenda really quickly, but it would have been emailed to you. I was going to go through some of these words that you said, but I think that was a very useful experience. I think we've learned a lot about each other. And what I want to say is that all of those words actually, let's bear all of those in mind today. Commitment, working together, hard work, respect, hope. So let's bear all of those words in mind as we work today. Okay, so quickly, let's go through the agenda. Coming up next is going to be Dr. Karen Broom. She's going to be doing a presentation on the situation of vaccination in the region and in the Caribbean. We're going to have a coffee break around 10:30, 11. And from there, Maite is going to take us through vaccine demand generation, what and how. After that, you'll have an opportunity for some questions and answers. We really want you to be engaged. We want to talk. We want to hear from you. We want you to ask all of your questions in this session. Our lunch break should be around 12 o'clock until 1. And when we come back, we'll be talking about immunization, data for action. Again, time for questions and answers. And Maite will be doing that session as well. She's working hard today. And then at 2 o'clock, I'll be sharing with you some results and findings from some of the surveys done in the region around vaccine acceptance and vaccine uptake. And we'll have a discussion around that. And I hope after that you will share some of your strategies that you have used in your countries. And we'll wrap around 3:30 or so. Tomorrow, I have another fun icebreaker planned. So we'll have an icebreaker again in the morning. And after that, Tanya is going to take us through the basics of risk communication and community engagement. And you'll have a chance to do your questions and answers after that. Then we'll be going into infodemia management, a hot topic. You've heard a lot about this during the pandemic, I'm sure. And we'll have some time to discuss that with the infodemic team. Thereafter, we'll talk about fact checking. Very important. We need to teach people how to check the facts as opposed to believing everything they read. Coffee break once again, and then we'll have a session on crisis communication and risk communication after that. We'll have lunch, and then it will be a session all about exchange of experiences. As you heard on Thursday, it's going to be all about ethnicity, diversity, and gender inclusiveness. And the team, some of whom you met online just now, will be taking us through most of that. And then we'll have a work group in the late morning. We'll have lunch, and we'll also have a pairing activity to go through a work plan of what's next. And then you'll present, and we will wrap. So that's how we're going to flow. So I'm going to not waste any more time. I may have taken some of Karen's time, but I'm going to ask Karen to come now to do the presentation on the situation of vaccination in the region and the Caribbean. Karen, over to you.
Thank you so much, Lisa. And good morning to everyone again. Don't try to follow me because I like to walk up and down. So I love a mic that's wireless, and I have my clicker. So I want to say a special welcome to the EPI managers that are here. That's the first thing. I spent 5 years as an EPI manager, and it is a job of love. That's the truth. You have to love EPI to stay with EPI. And we need to use some of that. We need to use some of that commitment, perseverance. I came into the EPI family as a young doctor, and I was taught all of my EPI by public health nurses, all. And those public health nurses knew every aspect of the program, every single aspect. And that's how we all must be, every single aspect of the program. In terms of communication and EPI work so closely together, and that's why I was so happy to see EPI managers here with the communication experts. Because if we don't work closely, we can't get that demand generation. we can't get that improvement in our coverages. And we really do need improvement. So I'm going to start chatting ad lib. And all right, here we go. We heard Mr. Chambliss talk about these achievements, and we've seen these achievements a lot. And there's something to be proud of. 30 years polio-free. What do we know has happened recently with polio? What do we know has happened recently with polio? Right, yes. We had a case of circulating vaccine-derived polio in the United States. Who would have thought? So we've been 30 years measles-free, many years diphtheria-free and rubella-free. But what does the case in the US say to us? So easily this can be lost. So very easily. So if we look at the state of our DPT-3 coverage in the Americas. Where's the pointer thing now? Oh, yes. So this is the Americas here. What do you notice? If we follow that line from where it came from, what do we notice? When we started, where were we? And we were up there. We were second. We were up there with the regions. We were high. And what has happened? As time has progressed, we have fallen significantly. And it's not just about looking at your coverage and saying your coverage has fallen. What does that mean? It means that there are children out there who have not been vaccinated. It means that there are children out there who have not had their full course. It means that there are children out there who have had no vaccination at all. In 2021, more than 2.7 million children, infants, in the Americas did not receive all their vaccine doses. Can we conceptualize of 2.7 million children? And we know that COVID has caused a lot of concerns with our health services. We had the lockdowns, then we were all involved in COVID-19 vaccination activities, and this really has led to this. But we can see that before that there was a downward trend, but it was just exacerbated. Oh dear, I'm gone clicker happy. All right, so again, these are, we talked about DPT-3 just now. This is the BCG, Hep B. So these are all of the vaccines. And you can see the downward trend. And this is the Americas, and we need to reverse this trend. Although we know that we have not had good measles coverage, we still have been able to keep our elimination status. We have not had any outbreaks of measles, but we don't know how long that's going to last. If we go straight to the Caribbean, we see our graph looks similar, but we tried. We tried in 2019, 2018, and we did see an increase in our coverage. So we know that our efforts there bore fruit. So we just need to make that similar effort again. Why do I feel that? All right, I want to show you 2018, 2021, and these are polio-3 coverages. So if we look at 2018 here, we see that we had 2 countries that were under 90% coverage of polio-3. What happened in 2019? We got 4. Look at 2020. 10 countries. Because we know that 2020 was full of lockdowns, full of access issues, full of anxiety and fear in the population. So in 2021, 3 countries moved from in the bottom there, under 90. So we're doing better, but we have to continue. Looking at our MMR coverage, because we know measles is always a huge threat. 2016 to 2021. What do you notice about this coverage? Same trend, same trend. In 2019, we really made an effort, but then 2020 came and we continue to fall in 2021. If we continue to fall in 2022, where will we be? Where will we be? So we have to reverse this now. And I know a lot of you are have a lot of activities going on to find those under-vaccinated and zero-vaccinated children. We've been beating the COVID-19 vaccine graphs to death. All right? I know you all must see these in your sleep. All right? So I'm not going to spend much time here. We know that some countries, unfortunately, have not yet met the 40% coverage, but I want to say something about this coverage thing on COVID-19. COVID-19 affects specific target groups. They're the ones that have severe outcomes. We have, yes, we're looking at 40%, but if we get 70%, and most of those are young children and adolescents, what is the impact? So we have to look at how many of our elderly have we been vaccinating? How many of our persons with chronic disease, how many of our immunocompromised? They are the targets that are important. All right? So if you can tell me that, yes, I didn't make 40%, but look at my elderly. I have 95% of them vaccinated. I have 90% of my immunocompromised vaccinated. That tells a different picture. So yes, we have these goals, but we must use them in a practical manner. We must use them in a way that makes sense. Let's talk about vaccine disease surveillance. Acute flaccid paralysis. That really is just how we look for cases that might be polio. So if we look, we're supposed to see 1 case per every 100,000 children under 15. If we look in the Americas, we have not even gotten that 1 case. 2021, 2020, 2022, we haven't gotten there. We have not met that target. Here, you can't even see the poor line. So if we look at rash and fever, suspected measles cases, this here that you're seeing is the suspected cases that were notified. So you see, before the pandemic, this was it here. We got all of these cases. What happened after the pandemic started? Very, very few, very, very few. And unfortunately, there's a line here that goes like this, which we can't see. But this line, this line that has this shape shows the number of COVID-19 cases. So you can see that with an increase in COVID-19 cases, you had a concomitant decrease in rash and fever cases. And you saw it in your countries. So this is nothing new. So that was America's. What's happening in the Caribbean? So 2017, rash and fever. 18 and 19, we did well. 2020, we apparently were seeing no cases, or we weren't notifying any of the cases. We were busy doing other things. 2021, very, very similar. All right? This, the target for this is what? Rash and fever target is what? My EPI managers. What's the target for rash and fever surveillance? 2 per 100,000. Are we anywhere near there? No, because look, the 2 is there. So we're nowhere near there. And the acute flaccid paralysis surveillance, we're supposed to be at 1. The graph doesn't even go to 1. All right? So this is saying to us that if we do not look for these diseases, we're not going to find them. If we do not look, you don't find, and you assume it's not there. But we saw in the United States, they had a case of acute flaccid paralysis, and what was it? Polio. So we must look. So all of this activity and weakening of our systems and falling coverage has not gone unnoticed. SciTag sent out a news alert in June talking about the decline in childhood vaccinations. And then WHO and UNICEF sounded the alarm about it globally. The challenges that we face as some of us are small islands and we don't have enough people. It's as simple as that. We just do not have enough people. We have high turnover of EPI managers, which means what? Every time you get a new EPI manager, that person has to be trained, that person has to understand the system, and it takes time for them to get to where they need to be. I know you all EPI managers are going to say, well, Dr. Broom, if you know this, why you don't do something about it? With several reports that you have to be completing all the time, all right? But there's nothing I could do about the reports, but I definitely can, and I always show you how you can get the reports done you can get them done quickly by just having the information that you need in one place. Because a lot of these reports call for the same information. That same JRF that you don't like, the same JRF that I hear, yes, hold down your heads. The same JRF that is always an issue and a concern, all of that, the reports that you just take it from the JRF. So if you do that one report well, all these other reports will fall in line. And then we know the EPI resources were used for the COVID-19 outbreaks. What do you think the EPI resources were used for the outbreaks? That's correct. There were the existing structures. They had public health nurses who were well trained. They had nurses who knew about disease surveillance. So if you have resources there ready, you're going to use them. So, but as a result, what happened to the EPI program? Suffered. Financial resources. A lot of countries in the Caribbean depend on tourism. And tourism in 2020, impact of Caribbean tourism costs region $33.9 billion. And we're seeing it. We're seeing it because a lot of you know the challenges that have been happening with paying for vaccines. You know that some of the invoices are not being paid. You know, because we see there have been an unprecedented amount of stockouts of vaccines in our countries this year. I know you all see my emails. Can you help? Can you help? Can you help? We spoke about it, vaccination coverage declining. We have increased numbers of zero-dose children, vaccine hesitancy. I know a lot of you have said to me, Dr. Broom, because persons had this hesitancy with COVID-19 vaccine, we are seeing the same hesitancy now trickling over into our routine immunization. And we have to pull that back. We can't allow that horse to get out of that barn. We have to pull that back. So we know we need interventions at the political level, the administrative level, the operational level. We know what needs to be done. And central in that is that we have to protect the EPI manager program. We have to protect the EPI program, sorry. However we do that, whatever support that is necessary, we need to protect the program. I think a lot of the political prioritization, we were a victim of our own success, meaning that we did well in immunization for so long. We were a flagship, so that we took our eyes off of the program, and then it started to falter. So we now politically need to put back our eyes on the program. Again, I want to reiterate, if we don't look for suspected cases of measles, rubella, polio, diphtheria, pertussis, we're not going to find them. It doesn't make sense that at our health centers that we identify a case of rash and fever. We send it to emergency room, we send it to phlebotomy clinic, wherever, to get the bloods taken, and they send that child home. If all of the stakeholders are not trained and understand why we must do surveillance, why we must look for these cases, we're not doing anything. Yes, you might be doing your job in the EPA program, but if the ER doctor, if the hospital staff, if when you go and say to the internist in the hospital, oh, this person has acute flaccid paralysis, we need a stool sample, never gets taken because they just don't understand or they're not interested. So we have to look at our systems. Lisa, are you motioning behind me that I need to hurry up? Okay, good. So we have to look at our surveillance systems. We have to do audits of our clinics. We have a lot of trust in our practitioners. But I would say to you, sometimes that trust is unfounded. We all need to go into our clinics and look at the patient notes that are done by the doctors. Because I assure you there's rash and fever there that has not been notified. If you have had dengue cases, if you have had Zika cases, you've had a rash and fever that needed to be investigated. If you've had viral illness, how many viral illnesses you know come with rash? A lot of them come with rash and fever. So we need to look at what is happening in our health centers. We need to train our doctors. We need to resensitize. Oh my gosh, every time I look up there and see my face, I get distracted. Sorry. So, key messages. The Caribbean Technical Advisory Group on Immunization had some key messages for all of the countries in the Caribbean. And they were that we have to focus on routine immunization of children under 5. Not under 1, not under 2, under 5. Why? Why under 5? Why under 5 and not just the cohort of under 1? That's correct. We have to find those that we missed before. Because if we don't find those, they're still vulnerable. So all that we missed, if I had a population of 100 children and I got 90%, that means that 10 still out there walking about without any protection. So we have to keep going back and making sure we find all of those children. In the monthly district reports, there is a section that talks about delayed doses. And I know you all always say, oh my gosh, Dr. Broom always want all this data, What we got to put the delayed doses for? And it is because it's just to help you track who you have found. That's why it's there. So that when I look at the data and I go to my boss, I can say, okay, in the Caribbean, we had 1,000 children we did not find last year. But so far, the countries have told me we found 600. So that gives me justification. It gives us a platform where we can say to the Elimination Commission, okay, they're looking for these children, they're finding these children. We spoke about lack of staff, and we have to look at ways to bolster what we have. A lot of us use retired nurses in the COVID-19 pandemic, and a lot of us use the private sector. And I don't want us to think that this is only something that happens in a pandemic. They can be used routinely with certain mechanisms in place. Because the schools were closed, a lot of our HPV vaccine coverages just were obliterated. And I use that word, obliterated, because they weren't in school and they didn't get the HPV vaccine. But now what good news have we heard about HPV vaccine? One dose, one dose. If you knew how long I was waiting to hear one dose, for years, that was my wish. And we have it now. So you only need to get them once. Only once. So again, here you see the priority for COVID-19 vaccination: achieve high coverage among the elderly and persons with comorbidities. That is what is important. But you have to first improve routine childhood vaccination coverage and the vaccination in the elderly and persons with comorbidities with COVID-19 before embarking in children 5 to 11 years. Of course, you have your children who are vulnerable, those with the severe immune disorders and other things, but the pediatricians can identify those people. So you don't have to do big public campaigns if you have not yet reached your targets in the elderly and the ones with comorbidities. We have to do our job in sensitizing those persons who we depend on to support our work in the EPI program, especially those at the hospital, especially those in the lab, especially our communication officers. We have to acknowledge the role they play and how important they are. So, thank you all very much. My presentations are not bubbly and happy like how I like to present, but I know that the work that we're doing now would allow me to do a bubbly and happy presentation next year, right? I want that promise from everybody that I can come and say, Caribbean for 2022, look at it, 90-something%. And that's what I like, that's the presentation we like to hear, all right? So I am here this morning. If you have any questions, please come and ask. All of you all know that I'm very easy to reach: WhatsApp, email, whatever, call. Sometimes you WhatsApp call me at night and I gotta quickly snatch off my night bonnet, but I am there, all right? So thank you very much.
Thank you, Dr. Broom. Sir? Yep. What? We do? Okay. So, basically, we're going to be talking to you about, this is COVID specific, right? Karen put this together for you. So this is the epidemiological update that was published on October 4th, 2022, and it gives you kind of a global and sub-regional overview of the immunization around COVID-19 and where we are presently. Okay, so what you can see here is up to Epi Week 39, and this actually runs all the way back to, let me just zoom really, really tight here, 2020, all the way up to, where are we now? All the way up to 20, pretty much 09? Yeah, so just before the beginning of this month. So you can basically see for Caribbean and the Atlantic Ocean islands, COVID-19 cases and deaths. And all of the lines you see below are the EPI weeks for the Caribbean, running from 2020 to EPI week 39, which was up to just before October. So during this time, weekly cases increased 52.7%, and that was primarily due to Puerto Rico and Dominica. And then at the national level, cases mainly increased in 8 out of 34 countries and territories in the sub-region. COVID-19 deaths, however, decreased by about minus 2.5% in the sub-region relative to previous weeks. So yes, we are having cases, but we are having reduced numbers of deaths. In 19 countries and territories with available data, in terms of hospitalizations, they reported either a decline or no changes in weekly hospitalizations. And there was a notable increase in weekly cases in the sub-region. In Anguilla, there were 7 new cases. In Puerto Rico, we had 7,583 new cases relative to the previous week. This next slide looks at the vaccination coverage rate against COVID-19 over the last 12 months. So that's running from October last year to September 2022. And it highlights pretty much all of the countries in our region. And just to point out that the orange is October 21st to September 2022. So that's over the year what has happened. And in blue, it was up until September 2021. So the orange is the change that has occurred in the past year. And you can see that there's been some changes, but for most of us, we are still below, a lot of us are below the 70% vaccination rate. Some countries have inched over the 40%. So remember, there was initially the 40% that was set. I think that date by which we wanted to reach that was that December last year? We wanted to get to 40% and 70% by right mid this year. So the 70% line is there. As you can see, a couple countries have reached it, but we still have a lot of countries that have not reached that 70%. By December 2021, 36 had reached that 40% target, and by June 2022, 17 had reached the 70% target. So now we move to the studies that have happened, because we want data for action, right? So in terms of the PAHO study that Maite alluded to earlier, it was addressing COVID-19 vaccine hesitancy, specifically among healthcare workers in the Caribbean. This was done because we see healthcare workers as a priority vaccine group. They are respected, very important influencers as it relates to health-related attitudes and behaviors. So our study was done, and it found a 23% of vaccine hesitancy among healthcare workers in the Caribbean. Only 4% stated an intention to refuse a COVID-19 vaccine altogether. I must say that this survey was done using, and it was an online survey. So the countries would have been given the link, and they were able to, and there was also a QR code. So if we had flyers, they could scan the code and do it on their phones, or they had a link and they could do it on their computers. There was one country that asked for printed surveys because they did not have good internet connections at all of the clinics, just to make it easier, and we did do some printed surveys for that country. So that's how it was carried out. We found that COVID-19 vaccine acceptance did differ among various subcategories and specialties of healthcare workers, and it was higher among nurses, 34% more than physicians. And we also found more hesitancy in the younger healthcare workers. In terms of hesitancy, it also varies at the time. Remember, this was done in 2020 and published in 2021. At the time, there was a lot of hesitancy around the vaccines that are available. And we're hearing the conversation now. People are looking for the bivalent boosters as opposed to what is available now. So history repeats itself. People were looking for certain vaccines. And as we were doing the analysis, I remember Maite and I used to call it vaccine shopping. People were basically vaccine shopping. They wanted this, they did not want that. And they refused to take certain vaccines because of, all of the misinformation and information that was out there. It was also, it varied also in terms of local, regional, and global events. And it varied with time. So for some countries, the territories that got vaccines earlier, when things were really, really crazy, people were more likely to take the vaccines earlier because they got it earlier. Things were really, really dangerous at the time. People who had to wait a longer time, their risk perception dropped. So we saw that it did vary based on where you were, it varied based on time, it varied based on how much information or misinformation or disinformation you were getting as well. In terms of respondents, 48% stated that the country of manufacture influenced their opinion on COVID-19 vaccines. If you cast your mind back, I'm sure you know there were certain vaccines that people thought were better, and they did not want some of the other vaccines that they deemed less effective. A lot of things happened in that time that made this really, really, really an issue. 47% of respondents also agreed that the development of COVID-19 vaccines may have been rushed, or they thought they were not thoroughly tested. And I think we know now healthcare workers as well did not totally understand the process of vaccines, and that these vaccines we did not start making the vaccines when COVID came. Then 30% of respondents also agreed that they did not know enough at the time about the vaccine, and they needed that information to decide whether to get vaccinated or not. And 30% also reported that the information they saw on social media shaped their opinion of a COVID-19 vaccine. And I think where we see social media, we should also consider WhatsApp, because Maite has her mom, I have my dad. Up to today, I still get 1 million messages on vaccines and what's real and what's not. What were some of the recommendations and what we found out of that? We found that educational campaigns targeting specific healthcare workers and subcategories, as well as targeting specific age groups, using different means would be likely to increase risk perception of the disease versus vaccination. So not just putting everything on social media. Social media is great, but we're talking about healthcare workers here. Healthcare workers are in a healthcare setting. So it means that you need to find other ways of communicating with them. And it's not just, as you've heard, it's not just about creating a product. It is more about engaging and talking with them. So that's where two-way communication comes in, allowing healthcare workers to express their doubts, their fears, without judgment. And I keep saying, sometimes in smaller groups. If you bring too big a group of healthcare workers or anyone together, people will hide. They may not say anything, or they will tell you what you want to hear. So you really have to, and I know this is hard work, you really have to have that, if not one-on-one, but small group conversations with healthcare workers. And to be non-judgmental, to make sure that you respond in a transparent way and give information that they can use. And identify trusted spokespersons among healthcare workers. Once you've done that groundwork, the healthcare workers then become your trusted spokespersons. There needs to be more capacity building, that's what we're doing here, more training for healthcare workers on communication about vaccines and vaccination, and more in-service seminars, group educational sessions, train the trainers, models, lectures, virtual courses. We have to go to work. We need to keep sharing this message. And it's not just about COVID-19 vaccines, even though this survey was about COVID-19, I think we need to continue to build capacity around this area. And involve healthcare workers in the design of communication products. Let them see themselves. Let them have a say in what the products should look and feel like. They are the ones facing the public. They're the ones who know themselves. They may have fears. And people tell them things that they may not say to other people. And that's what we need to know to help create messages that will really resonate. We also need to improve their access to vaccination. Offering it at work during convenient times and allow workers time off if they need time after vaccination. And as we said, motivational intervention. So using champions, trusted spokespersons to address the concerns around vaccination. So on to another survey now. This is a survey that was done by CARPHA. It was also an online survey. They're relatively easy to do, so most people use online surveys. This one was mainly done on social media. So CARPHA would have shared this on their platforms. They would have sent it out as an email blast to member states. And in total, they got about 2,302 individuals from 6 CARPHA member states. And in total, 51% of people at that time had received a vaccine for COVID-19. And among those who were unvaccinated, 46% said they would get the vaccine when it became available. So those are immediately the persons who we would term as hesitant. 32% said they may get the vaccine if available, also hesitant, and 22% said they will not get the vaccine if available. So we would see those as possibly the anti-vaxxers. In terms of COVID-19 vaccine acceptance, they rated that at 74%, which we thought was fairly good at the time. I won't go too far on that right now. And then it said that 15% were identified as hesitant, and 11% said that they would not accept the vaccine when it became available. CARPHA broke down their reasons or concerns around COVID-19 vaccine by age, education, area, gender, and healthcare worker status. So on screen, you only have age and education. Remember, we're going to share these with you, so don't bother try to squint in and see. But it basically just gives you some of the things that people said in the different age categories. So for instance, in the first category, persons who are 18 to 19 said things like, I'm concerned about the possible side effects. I think the vaccine was developed too quickly. I don't think it will protect me from getting COVID-19. I don't know enough about the vaccine. And to be honest, those were the main things that people said. The participants got most of their trusted COVID-19 information, they said, from scientists, doctors, health experts. I'll say that again. They got most of their information, trusted information, from scientists, doctors, and health experts. So yes, there's a lot of information out there, but they say that they trust us, right? And you see the percentages there, and also from public health organizations. And this did vary a little bit between their geographical regions and also their level of education. In terms of education, the more knowledge there was about COVID-19 expressed, the less likely they had concerns about COVID-19 vaccination. So education is really important, and sharing that information from trusted sources was also deemed to be very important. This survey was one done by USAID and UNICEF, and it was carried out by Cadres. It was done in 2021 and covered the countries Barbados, Dominica, Grenada, St. Lucia, St. Vincent and the Grenadines, and Trinidad and Tobago. And basically some of the general views and opinions on the vaccination of children, they focused a lot on children, was the main thing that came out at 17% was that the children were too young to be vaccinated. The next highest point was 9. It's a choice, and I choose not to vaccinate my children. Followed by I don't trust the government and medical authorities, and my research tells me it's not a good idea. So this is where parents were speaking about if they would vaccinate their children. When parents allowed their children to take these vaccines, this tended to follow respondents having done more research or speaking to their doctor or pediatrician. So what is it you're hearing again? As much as they have those social media and their WhatsApp, they're going to go back and talk to their doctor and the pediatrician, right? And when they're ready to make a decision. And you note the mistrust of government. Sometimes government medical authorities or just government in general. In terms of the factors that changed their minds, the highest was did more research and spoke to my doctor. I sometimes question what did more research means. As Maite said just now, every journal is not a journal to be trusted, right? I can't wait till the infodemia management session, because Tina and her team will tell you that every picture is not even a real picture. A picture that is next to a story doesn't mean that that's really the story from the picture. And I have been teaching my 76-year-old how to fact check. And you have to do it. You have to show people that just because something came to your phone, it doesn't mean that it's real. And there are ways you can check it. So now he's a Snopes person and a Reuters fact checker, and he checks. And then he shares it in those same groups where people are sharing foolishness. And I love it. Okay, so here are a couple profiles of the unvaccinated from that same survey. The same countries we mentioned before. And for the most part, they're fairly similar. The unvaccinated in most countries were, I don't want to even say most, they were male or female, but they seem to be more male. They were under 50, but then again, remember this was online survey as well. Most of the people were educated to secondary level in this survey. There was a lot of talk about distrust, so trust was a big thing. And people again said they felt it was developed too quickly. That was in Barbados, in Dominica. Grenada was strong on choice. It's my choice. I choose not to, as opposed to talking about the lack of trust. Trust was also seen in St. Lucia and in St. Vincent and also in Trinidad and Tobago. So coming out of that was, yes, the whole talk about it was developed too quickly, but it was a big mistrust issue, right? So that's what came out of really and truly all of those surveys to me. In terms of the factors that could possibly change their minds, the highest rated factor was more scientific or medical information, and that was followed by if it was a requirement to travel overseas. So someone mentioned this before, they'll get that yellow fever because they gotta go. That was definitely something that motivated persons to take the COVID-19 vaccine. Also important was when they saw people they cared about getting sick or dying. That was a motivating factor as well, and security to maintain a job. So that's where those mandates definitely influence. But we also saw the blowback from the mandates across the region and across the world. So some of the recommendations that came out of that was that communication strategies need to speak to people's key concerns. They need to target the demographic group specifically of the unvaccinated and exploit non-governmental personalities. Unfortunately, a lot of people do not trust government authorities. And there are times where we might be roped into that. So yes, they trust doctors and nurses, but sometimes they see us as a mouthpiece of the government. I say us because it used to be me, used to be there. But still, in a sense, seen that way from PAHO. So that's why we're talking a lot about community engagement, working with people who are already working in communities and not expecting that you always have to be the one out there in your Ministry of Health shirt saying, get vaccinated. That can backfire, right? And then there are also supplemental strategies that you need to consider in terms of the risk of vulnerable groups. And I think Karen talked about this morning, focusing in on those groups that are really vulnerable. Not that everyone is not important, but really focusing on the vulnerable groups to COVID-19. Also, in terms of younger and unemployed persons, a lot of younger people felt less risk for COVID-19. And I think that might be linked into what we talked about just now, as Maite said. And I'm not that young anymore. I don't know much about, polio and measles. I don't have any memory of those things. And I think younger people just don't have that memory to help them to say, well, this is important. And even for COVID-19, they've never taken a flu shot. So for them, why would I take a COVID-19 vaccine? And then to use different products. We don't need to do the same thing all the time. I spoke to, I think it's St. Vincent, either St. Vincent or St. Lucia or Grenada was talking about doing a drama, a soap opera of some kind that incorporated COVID-19 vaccination, using different means to get the message across. We need to do things a little differently. And then tracking vaccination is really necessary to determine if the strategies are working. So that M&E that we all go, oh gosh, the M&E. We need to track to see after we've done a campaign, if anything has moved, and then evaluate if we need to make any changes. And they suggested that they repeat. If the strategy has worked, then you repeat it. If not, you make the changes that are necessary. And that is pretty much it.
There we go. Thank you. So demand, vaccine acceptance, and hesitancy. What is it? It is not new. WHO has actually been studying vaccine hesitancy since 2012. It isn't something that just sprung up from COVID. Of course, with the COVID pandemic, it has become more heightened, let's say. The COVID pandemic has put like a limelight on hesitancy, acceptance, what it is. And actually in 2019, before the pandemic, WHO named it a risk to public health, vaccine hesitancy, because we know the reintroduction of vaccine preventable diseases could have on our programs and everything. So what is vaccine hesitancy? As you can see in the circle right there, it is between refusal of vaccines and it is between the acceptance of all the vaccines. So if someone is refusing vaccines, they're no longer vaccine hesitancy, they are refusing the vaccine. So just to keep in mind that when we talk about hesitancy, we're talking about this people in the middle, people that can be moved. And the thing about vaccine hesitancy is that it can change. Some persons might be on this side of the, right here, where is the pointer? There we go, right there, when we're talking about COVID vaccines, but when we're talking about childhood immunization, they might be right here. So people move throughout here depending on the vaccine, depending on where they're at in their life, their age. Maybe when they were teenagers, they were okay with vaccines, and as they grew older, they became more hesitant, or the other way. So this isn't something that when you fall in this scale, you will stay there for the rest of your life. You will move, and people move there all the time. It also depends on your beliefs. Your religion can influence it. The people who you live, your friends, your family, your political views can influence all of this. So just to say that is a very complex issue. Vaccine hesitancy has a lot of different things coming into it, and not just one thing that makes a person decide whether to choose to get themselves or their family or the people that are in charge to get vaccinated. Let me see if this is working. There we go. So what is this? This is called the 3C model. These are basically the reasons behind vaccine hesitancy or vaccine acceptance. First is complacency. We've seen this a lot lately with the EPI program. And I was just telling Karen, we're actually, our success is actually our demise. People haven't seen vaccine preventable diseases in a really long time. And therefore, the risk that they perceive for themselves for these diseases is not there. They don't think these are diseases that can harm them or their families or have an impact on their livelihoods or their health. Therefore, they choose not to get vaccinated and they become complacent. So that's complacency right here. The other thing is confidence. Confidence in what? Well, in the vaccines themselves, confidence in their healthcare system, in their practitioners. It could be confidence in their governments, confidence in the Ministry of Health. So just confidence in the entire system that supports vaccination. Do they trust it or do they not trust it? This can also influence their vaccine-related decisions. And the last one is convenience. And this is more related to the program itself. Is it, for example, if I'm a single mom and I need to take my kids to get vaccinated, is the clinic open after I'm out of work? If it's not, then I'm probably not gonna go. Or is it open on the weekends? Is it, when I go, do I have to wait 3 hours at the healthcare service? When I go, is someone there greeting me nicely, warmly? Does the healthcare worker is trained? Can they answer my questions? So all those questions and issues that come up when a person decides to get vaccinated and they go to the healthcare system, that is convenience. Also, for example, maybe I live super far away from the healthcare post or from the clinic. How am I going to get there with me and my children? All of that is convenience right there. So all of these three are kind of intertwined, and they also influence our vaccine-related decisions. The other thing, so this is the vaccine hesitancy determinants matrix. I was just talking about this. Besides the convenience, the complacency, and the confidence that we have in the system, all of these influence how we make decisions related to vaccines. So we have contextual influences. What is this? The communication that we receive from the media. This has become a very, 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 very important. I can't emphasize on the very. This past 2 years, we know how much people are receiving information about vaccination, how much they're researching topics about vaccination. So this right here has become increasingly an important point. Also influential leaders. We know that some people listen to, for example, what the pastor at their church has to say, what their community leader could be, a neighbor. Sometimes I get it from my mom. She calls me, she's like, oh, my neighbor told me this. What do you think? I'm like, listen, Mom, don't listen to everyone. Just, get the sources, get to the facts. So this also right here, a very important thing. In this historical influences, we've seen this in some communities where there's been, and we are aware of, racism, There's been issues with how the healthcare system has approached them. There's been issues on how they've been engaged to be part of research questions, research studies, so they don't feel represented when it comes to them being the receivers of the vaccine. So this can also influence how they're seeing. Of course, like I said, religion, our culture, our gender, our sex, these are all influencers. Politics and policies, you can tell me more than I know how politics have influenced COVID-19 update vaccines in this past 2 years. And now it's probably influencing the regular program as well. Geographical barriers, I just spoke about them. Can people access the healthcare to begin with? And this one is important too. Lately, how do they perceive the pharmaceutical industry? So they think that of course, that they think that they're only there to make money, that there's an ulterior motive as to why they're promoting this vaccine. So all of these are contextual influences. We also have very individual group influences. These are the beliefs of your family, those around you, your community, what they think about it. How does that influence yourself when it comes to vaccine-related questions? Just to say, we hopefully will share all of these presentations with all of you, so you don't have to take photos and you can take them home with you if you ever need to. I also have a list of resources where all of this is coming from. So all of this, look, I think the most important out of all of this is the relationship the person has with their health system and their healthcare provider. We know that a healthcare provider recommendation is one of the strongest forces. So if I go to a healthcare provider that I know, that I've been going my whole life, some of us have been going to the same healthcare provider we've been seeing since we were kids, if it's a family doctor, right? So if they recommend vaccines, that also has an influence. If they don't recommend it, I'm sure it's gonna have an influence on us as well. And this one right here, the risk benefit, this is all what I was just talking about. We haven't seen vaccine preventable diseases, Karen was just telling me, in the Caribbean in years. So it's hard for us to communicate to the public, listen, I need you to take your children, you need to take your children for their benefit to get the vaccines if they haven't seen the disease. If they haven't seen a polio case, a measles case, a diphtheria case, rotavirus case, they haven't seen these cases, so they don't think it's relevant for themselves at this moment. They don't have in their mind this perception that the risk that I'm taking when I'm vaccinating my children outweighs the risk of the disease. They don't have that in their mind. So this also influences. It could be the other way. People do see that vaccine preventable diseases are a risk to them, to their communities, and therefore they go and they get their kids vaccinated. And the last one, not the last one, but another one is these are specific issues related to the vaccines themselves. It could be cost, it could be reliability or supply. Let's say I took my kid to get vaccinated and they told me at the clinic, we don't have this vaccine anymore. Sorry, we ran out. That's a problem because the person was already there and they were willing to get the vaccine. But when they went in, they were like, oh, you have to come back tomorrow. Well, I already took off today. I don't have the time to come back tomorrow. What am I gonna do? I'll just push it for 2-3 months or maybe not come back ever again. So all of these things related to the programmatic issues or the programmatic part when the person has decided to go there also affect not just for that specific vaccine, but it can also affect in the future how they make the decisions related to vaccination. I'm having issues with this clicker. There we go. Okay, so this is the matrix of the determinants. Like I said, all of these determine person's decisions. It's a very complex decision process that we have to understand that it isn't just one factor. And when we create communications campaigns, we have to keep this in mind to make sure that we try to address as many factors as possible through our communication, through our community engagement, through our speaking with the public, through our messaging. I'm having issues with the clicker. There we go. Okay. The thing is, communications is not really a determinant of hesitancy acceptance. It's more of a tool, how we communicate about it. But if we communicate poorly, it can have an impact on the trust in the vaccine, in vaccination, and in the program. So that's something very important to keep in mind. It's not like communication will influence decisions, but it can have an impact on the trust. And also, if we do a good job, it can also have an impact on the trust. Uh-oh, no, I went back. Sorry. Okay, so what is the difference between acceptance and demand? Hesitancy affects demand. That means that from the moment the person has made or has not made the decision to get vaccinated, there's a whole journey that they have to take, which means getting to the healthcare system, making sure that the health services are in place for them to take the vaccines when they've made that decision. They're very similar, but they're not completely congruent, like you said, you see here. High levels of hesitancy can mean that demand will be low, but low levels of hesitancy will not necessarily mean that there's high demand. People can accept vaccines, but that doesn't mean that they're going to go demand it to the healthcare system and they're going to say, look, I want my vaccine, I need my vaccine. It doesn't mean that they're going to take that extra step, which is where we fall. We want to make sure that people accept vaccines, but they also go and get their vaccines. They not just stay at their home saying, oh yeah, the vaccine is great, I'm not going. You know, just from the communication point, we have to help them or push them to make that extra step to get to the healthcare system. So like I said here, ensuring that we have demand for vaccines. And what does this mean? The people are constantly going to the healthcare system and demanding that they get vaccinated or demanding that the program is available for them to take their vaccines they have to go beyond addressing hesitancy. It has to go beyond messages of saying the vaccines are good for you or, you know, this what you're thinking might not be correct, all of that. It has to go beyond to make them not just accept it, but increase uptake, which is the ultimate goal, support the EPI to support the EPI to increase vaccine coverage. Okay, so all of this to say that for a vaccine acceptance and demand plan, for it to be successful, we have to take into consideration different components. It's not just communications campaign. It's not just having the services available. It's all of this. We have to think about it as a whole, and then we have different pieces that will feed into it. Why I'm presenting this? Because throughout this whole week, you will hear on some of these specific components. For example, later today, I'll talk about how collecting data and how using that data can help us as communicators improve our campaigns. Tanya will talk about risk communications and community engagement. Why is it necessary? It's part of the IHR regulations. Yeah. Infodemic management, the WHO team will have a presentation on what is the infodemic, how do we manage it. Crisis communication, someone was talking about ESAVI this morning. Why is it important that us as communicators have our teams ready to respond from the communication side to when an ESAVI happens? And for those of us communicators who don't really know what an ESAVI is an adverse event that is attributed to vaccination. It could be or could not. There's a whole investigation around it, but usually they have an impact on the program because they can undermine trust. So crisis communications for ESAVIs is actually very important that we have the knowledge on how to respond to it. There's also advocacy and stakeholder engagement. Someone was just talking about engaging our stakeholders. We know that we, PAHO, and you at the Ministries of Health don't operate in silos. We have to work with the people in our communities. We have to work with other stakeholders, other Ministries of Health, other international organizations, leaders at the local level, whether it is, a church, whether it is the school, whether it is the teacher at the school, the local leader at your church. I don't know how it is in the Caribbean, but in South America, we have there's community associations, like all the neighbors in a small community, they get together and they elect someone that will represent them at bigger forums. All of those people, how do we work with them to get them to be promoters of immunization with the public? Also capacity building. This is extremely important when we're talking about healthcare workers. We need healthcare workers to help us carry out this message. We need community workers to help us carry out this message. And of course, the lovely M&E, which we all love to talk about, but it gets forgotten a lot. So, some of these components, data collection. So why collect data? I will talk about this in a more deep way, but it's important to understand what our people are thinking, How are they feeling? What are their attitudes, their practices when it comes to vaccination? Otherwise, we can't design effective communications campaigns. Like, we need to know what's happening out there for us to say, okay, people are having a fear that this is happening. How are we going to address that? But if we don't know that, how are we going to create our campaigns? Like I said, this will help us select our activities and plan for it. And how do you do that? Well, you can do desk reviews. With COVID, there's a lot more information out there on how do people perceive vaccinations, how do they think about it, what are their practices around it. You can conduct surveys, they're a bit more expensive. You can conduct focus groups, polls. You know, some of this data collection part is more like gray literature and other type of scientific literature than it is social media monitoring, but that can also help you inform campaigns. We are seeing now that the use of social media has increased, especially when it comes to vaccination. Like, how do we use all of this information that we have to create communications campaigns? So all of this has to be taken into consideration. Obviously, the coordination and planning, you probably know better than I do, who are all the actors that need to be put in place so we can create a plan, so we can implement it at the national level and at the local level. So who are your partners? Is it PAHO? Is it UNICEF? Is it the civil society? Is it the private industry? I know in some countries there's been great success with partnering with the industry side. For example, Digicel, I believe the PAHO Caribbean office has been working with them to get messages of how do you engage with these people. You have to engage them, of course. You can't work in silos, like I said, and you have to meet regularly and keep them informed. This will ensure that throughout the plan, everyone's carrying the same message. Otherwise, if one thing is someone saying something and someone saying something different, that also affects the trust that people have in you and your program, And then the Ministry of Health. RCC, I'm not gonna say a lot about this because our XCC expert, Tanya, tomorrow will talk about it. Like I said, it's part of the international health regulations. And what is RCCE? Well, it's basically helping people make health-informed decisions through increasing their risk. It is a two-way dialogue between health authorities and the audience, and it helps you strengthen your response, your leadership, and your confidence in yourself, who are the health authorities. Infodemic management and social media. So we hadn't really heard anything about infodemic management before the pandemic. It's been a child of the pandemic, let's call that. Infodemic management. So why is it important that we tackle this? Monitoring social media, it's important to track information of what's happening in social media. We know that that's where people share their opinions, that's where they share information with their friends, that's where anti-vax news go viral. You know, anti-vax sentiment, it was, I would say, heightened by social media. All the anti-vaxxers sort of poured into these like public forums and they just started spreading their information. So it's very important that us, from the communications point, we see what's happening. It can also help you understand if there are issues with the healthcare service. If someone's going on social media and complaining that they took their kids to the health service and then the vaccine wasn't available, then you can also pick up from that what is the issue and how you can improve that. Like I said, anti-vax sentiment, fake news, misinformation, disinformation, that all happens in social media and sometimes in the traditional media. So it's important to keep an eye on what's going on here, and then that will help you produce messages and communication that could help you counteract this. So monitoring this is actually very important. And like I said here, it can help you mitigate rumors and disseminate accurate information. What we will be hearing also, I believe, tomorrow is on how to fact check information and how does that look. They'll also be presenting, there will be a presentation on how do we help people address rumors, how do we help people figure out what is inaccurate information, what is fake news, and how they can actually access better information, reliable sources, and not just what we've been hearing, sort of like pseudoscience, people that pretend they are experts on the knowledge, but they're not really, and they use this jargon science language to get to people, and then people think, oh, they're real expert, but look at them, they're not. And look at this, I saw in this, they're called predatory magazines, I saw this article, here's the article, you know? So how do we do that? Crisis communication, we'll also have a very nice presentation on crisis communication.
like I was mentioning, this is an important component to your ESAVI surveillance system. Is part of the, I think some of you have attended the trainings that have been done on this specific component and on the bigger ESAVI surveillance. This is specifically related to vaccine safety events. It's not crisis communication for other things. Of course, if you think it helps, it can help you in other things, you know, response to hurricanes, all of that, but this is crisis communication for vaccine safety specifically. How do we communicate with the public when we're talking about an ESAVI? How do we communicate with the public when it's something that could undermine the trust of the immunization program, like a change of a vaccine? Let's say today you're using a certain vaccine and then tomorrow for something happens and you have to change. How do you communicate that? And of course, this has to have a specific plan. Besides this big demand plan that has to have all these components. Crisis communication requires a specific response just because of the potential impact that it can have on your program. Advocacy, well, obviously advocacy for proper budget allocation. Things are not free. People's times are not free. Ad placement is not free. So I think we've seen it now, and more so now. How do I say this? In the past, working in comms has been hard because, you know, they asked us to do a lot, but they never give us a real budget to work with. Never. And I see some heads just going, it's true. Like, we've seen it at PAHO. We used to have zero money, but now with COVID, I feel like it's a good thing because they've seen the importance of communication and health promotion, and they're giving us money. But that's for COVID. So what happens now? You know, we need to advocate from our side. If you want me to do this, I need resources for the regular program. Vaccination doesn't stop when COVID stops. It continues. We have to keep pushing for this when it comes to the regular program. And this part of this advocacy and stakeholder engagement is specifically that. It's, you know, talking with donors or talking with partners like PAHO. I'm not saying that we're gonna give them money, don't worry. I'm just saying that this is something that I can see Dean and Karen's face. It's just that this is a conversation that needs to happen. Things require money, communication campaigns require money and people and resources, and this is part of that. And like I said, other stakeholders. So who are other stakeholders? Well, it could be leaders at the community level. It could be, I don't know, professional associations like pediatricians associations or nurses associations. Your NITAG, for example, is a wonderful stakeholder that you should be engaging when you're thinking about your communications campaigns. Your NITAGs have a lot of knowledge on the program. Some of them have some comms experience, so engage your NITAGs when you're thinking about these demand plans and trying to get feedback from them as to what do they think are some of the things that they're hearing from their colleagues and how you can implement that in this plan. The issue of capacity building, I listed a couple examples here. You know, working with your healthcare workers so they understand not only the technical side of it, but they're also trained in bi-directional, face-to-face communication with their patients. How do you listen to someone proactively? How do you listen to someone with empathy? If someone that is hesitancy comes into your service and they have questions, how do you make them feel that they're not judged? How do you engage in a communication that, or in a conversation where at the end of the day, you might have moved them closer to the vaccination side than to the, you know, refusal side? The interactions with the healthcare workers have an enormous impact on how we make decisions when it comes to health-related things, not just for vaccination, overall. So training healthcare workers on how to answer these questions, how to engage with their patients, or even just, Karen was just talking, I think, about missed opportunities, is that if a kid comes into the healthcare system and they've come for a broken arm, how to make sure that that healthcare worker is gonna say, hey, are you up to date with your vaccines? Like, have you thought about getting vaccinating, talking to the parent, helping them make that decision? All of that has to come when it comes to engaging healthcare workers and building their capacities for them to answer questions to the public. We're not here to judge, we're here to answer the questions of the people that might still have some questions and might still be valid. And, you know, even to hear those who are completely refusing, we just wanna know, you know, engage in a conversation that is mutually respectful. Community workers, a lot of countries employ community workers to go and do services in the small communities. They're sometimes part of the healthcare system. So also not just working with, professional nurses and professional doctors, but also talking with community workers that might have even closer relationships with your communities, with your public than some of these healthcare workers might. And capacity building and community leaders. I was just talking about leaders that are very influential in communities, like your religious leaders, your church leader, the deacon at the church, your pastor at your church. People listen to them. People go there every Sunday. Some people go there every day to hear what they have to say. So if you talk to these people, and I know some of them, of course, like everything, there's some that are very anti-vax, some that are very pro. How do you engage these people? You have to keep in mind that you have to engage them. They have to be one of your main allies when it comes to talking to the public. You need their help. You need this bridge. They are a bridge between you, the government, you, the Ministry of Health, you, the program, and the community. They can help you as a gatekeeper openers. They can open the communication to the communities for you to go in with the services, with knowledge, with information that can help them make these vaccine related decisions. And of course, obviously our lovely M&E. Why do we do that? Well, we're hoping to get some achievements, what we did right, improvements, what could have been done better, and some lessons learned. This issue of the lessons learned has become really important too in the past 2 years when it comes to immunizations. Countries like to hear what other countries are doing and how are they successful. You can also get ideas from what other people are doing in other countries, and see if that might be a good fit for you or not, if maybe you can tweak a couple of things and then implement it in your country. So recording and making sure that you know what your lessons learned are, all of this is important, not just for your own country and to improve your plan overall, but for this collaboration that we've been hearing, this Caribbean collaboration around the region, and see what can we do that's been working here and we can bring it here. What can they do that's been working here and they can bring it over there. Yeah, that's it. And last but not least, resources. Oh my God, sorry. What's happening with this clicker? Okay, there we go. So resources. We have some lovely resources on, these are all technical documents that can help you create a robust demand plan. For example, we have a whole, this one right here, this link right here is my favorite. It is an Excel template that already has ideas for every single component. So what activities you can carry out for all of these. This one right here, this template, and how to create an acceptance and demand plan. I know it says COVID-19 vaccines, but you can think of it as a vaccines in general. It's only, it was developed for COVID-19 vaccines, but you can adapt it to be for the entire program and for childhood immunizations. The template right here, this is just a guidance document. It's not, it's just like, it tells you how to use that template, but the template right here already has examples. It has a very lovely template on how you would go about creating this plan and what are the things that you need to take into consideration, like timeline indicators, some examples of partners, all of that. So that's here, right here. This tool right here is more for the data collection. I'm going to be talking about that in the afternoon. So how do we use data on the behavioral and social drivers that I was just talking about to improve our programs and our communication with the program? So how do we use all this data to create programs that are answering the issues, the questions, the knowledges and the practices of what people are thinking and saying? Communicating risk in public health emergencies. Tanya will be talking more about that, but that is on the RCCE. We also have this guide that, like I said, is also COVID-19, but can be used for the program in general on how to create a specific plan for crisis communication and community participation, and for crisis comm that I also will be talking more in depth later, the crisis communication for vaccine safety. And this is like a technical guidance that also tells you about the specific steps that you have to follow when responding from the communication side to a vaccine-related crisis, so an ESAVI or a change in a vaccine. Why do you want to gather this data? What are you hoping to achieve? Who do you want to focus? Who is it, caregivers on a specific vaccine? Is it their feelings on the program as a overall? What are the barriers that they're facing? What are the enablers that they're helping them take vaccine-related decisions? Are you going to focus on one specific set of population? Maybe it's a rural community. Maybe it's people living in the peripheral urban areas. Who? This is the most important. Based on that, you'll be able to figure out what is your research question. Like, what do you want to answer with that? The second one is create a team. Like I said before, we don't work in silos, and cooperation is very much needed. So who are your key stakeholders within the Ministry of Health, within your government? Do you need, Ministry of Education if you're trying to get to students? Do you need, I don't know, the tourism industry if you're trying to get to foreigners, if you're, or visitors or tourists? Just think, and is it PAHO? Will PAHO help you? Would it be UNICEF? Would it be maybe, the University of the West Indies or another academic partner that can help? Usually they have a lot of knowledge when it comes to research. Who in your team could help you develop this and then make it a better process? And then obviously, what are your needs, right? Like funding needs, do you have any needs? Your timeline, and this guy right here, we were just talking about it at lunch. Ethics requirement. A lot of our projects have stalled this year because of ethic requirements. Going through your national review board, going through other review boards that you might have in your processes. It's important to include this in your timeline and give it enough time, because this can make or break your project. A lot of projects that require talking with people require IRB. So you have to make sure that you go through it. I know it's cumbersome, I know it takes a long time, I know it's a very detailed process, but it will help you make your project better because it's a fresh look. And then obviously develop your time and budget. So when it comes to next is choosing your tools. This, I think it's very important because it will help you answer your question. What tools do you want to use? Right? Like, how is it going to be your data collection? Is it going to be online? Is it going to be a survey in person? Is it going to be a focus group? Is it going to be one-on-one interviews? How are you going to get to those people? Is it going to be a purely quantitative survey that you just want to get a big scope in the whole country? Or are you going to do a more qualitative, small face-to-face interaction because you're trying to get to the bottom of what's happening in a specific group? How you choose your tools will depend on what your goal is. You have to make sure that you match your goal, and then based on that, you will select your tools. The other very important thing is you have to adapt the questions and your tools to the public that you're talking to. And how do you do this? Well, you can conduct piloting. You sit down a couple people from the community and you ask them the questions that you would think you would ask them. You have to make sure that they understand what you're asking them. It's happened to us before when we've designed a survey and when we've piloted, the people didn't know what vaccine coverage meant. They didn't know what vaccine uptake meant. We know those terms because we work in public health and we are around them the entire day and we hear it all the time, but the public, the regular people out there, they don't know. So you have to make sure that what you're asking is coming across and the message that you're trying to get from them, you can get with the questions that you're asking. It's also very important to, excuse me. Oh my God, this thing is not my friend. Translate, I know in Belize, there's indigenous people. So make sure that you're talking to them in their language in a way that they understand what you're asking is very important. There's some Creole spoken throughout the Caribbean too. Are these people more comfortable talking in if it's Creole, their maternal tongue? Is it something you have to consider, whether it is English or Creole? All of these have to be taken into consideration. Otherwise, your data might not be as good as it needs to be. In the document, there are some priority questions that are tied to indicators. If you can, and if you're ever using this data to create a survey, try to not change them. This document has gone through an entire global process, which it's involved a lot of experts from throughout the world. It's been piloted in several countries. And that's why they've come up with these specific, I think there are 5 questions at the beginning that are set, and they are tied to indicators, so try not to change them. And last but not least, identify your sample and your data collection protocols, and then again, any necessary approvals. Might be internal approvals, external approvals. If you're working with PAHO, PAHO has its own approval. How are you, what is your sample size? How are you determining your sample size will be tied to the tools that you're using. Same with the data collection. And here, more on the data collection. I think from my experience, and I'm not a statistician, what I've seen is that engaging statisticians and people that know how to do this from the beginning will set you up for success. They can help you define your survey. They can help you collect the data in a way that it will be helpful. They can help you clean the data and then analyze it, and also come up with an analysis plan for your protocol that you probably will have to present to your IRB or to your ethics review or to whoever. So those are the plans, right? The steps: collect, clean, and analyze data. When we were talking about collecting, what are some of the methods that you could use to collect? Is it face-to-face? Well, what do you think are some of the, I would say, advantages of face-to-face collection? Anyone? Yeah, go ahead. I don't know if we have a mic. Oh, you have one. Great.
Persons would refrain from telling you certain things. Sometimes they are not even honest.
Okay, yeah, so that's a disadvantage of face-to-face. Anything else? Yeah.
You immediately are able to get feedback. So if a question is
Exactly.
asked and it needs to be cleared up, you can provide that response.
Exactly. Anyone else? No? So yeah, go ahead.
You may be able to kind of interpret for them, or like relay how you're the question you're trying to ask if they don't understand as well.
Right, yeah. So usually face-to-face collection, you get more responses just because you're right there. People are more willing to answer you and give you a bit of their time. Like you said, it's better understanding of the questions, and the follow-up is, I think, the number one thing of face-to-face. You can ask more questions, you can get more information, especially if it's like a qualitative type of study, then you get more information than if it's just an online survey, right? The problem with them is what the colleague was saying, it can create what is called socially acceptable answers, right? People don't feel as comfortable sharing what they're feeling, what they're thinking, so they might just tell you something you want to hear. And also, it's very time and resource intensive. You need a lot of people that are trained in giving the surveys, the questions, and it takes a longer time, right? And they're usually writing it down, and then cleaning the data from that will also take a longer time. So it depends on what your survey is or your study is trying to get, or what methods you're going to use. The other one is telephone. What do you think about telephone? Like, what are the pros and cons of like telephone-based interviews or surveys? Yeah, go ahead.
I think one of the challenges now is, in the age of scamming and so on, you have to first and foremost cross the hurdle to establish that you are legitimately calling from
Right.
whichever entity.
Right, yeah.
That's also a good way to get people to actually want to participate, because if I'm at home, if I'm doing something or so on and so forth, it's in real time, so you don't have to take out time from your
Right,
regular
convenience.
day or anything like that.
Yep.
You can get some more in-depth analysis, for example, emotions, from the, facial gestures. That's if you would have them face-to-face, no? Contrast to just listening on the phone as well.
Yeah.
So that might be one of the cons to it.
With telephone interviews, the person you're interviewing might not be as intimidated as with the face-to-face interview, because some people are intimidated with face-to-face interaction.
Yep.
I think it's one of the positives, as was said, it allows for
persons don't have to go. But one of the disadvantages, like for me, I don't like telephone interviews. I just want to get off the phone. So it may limit the amount of information that you would get because the person just want to just get rid of you. Yeah.
Yes. Yes, everything, exactly. The thing with telephone interviews is that you are limited by a lot of time people have to give you on the phone. No one wants to be on the phone, especially my generation. We hate talking on the phone. Come on, if someone calls me that I don't know, I'm not gonna pick up, right? Like I'd rather text. But you can also have this bit of an anonymity that can help you, be more open with your answers, the less socially acceptable answers. Yeah, go ahead.
I just wanted to add, for instance, for Guyana, for the hinterland regions, telephone is not possible.
Right.
So.
Yep, I was just gonna say that. There's also a limited source of people you can get to, which is also the same problem with online surveys, right? And it's less time consuming than face-to-face, but you still need resources. You need the lines. People have to have a telephone, so that already creates a bit of bias of who you're interviewing and who is part of. Sorry, I'm not talking into the mic, sorry. Yeah, but I think, every different tool that you have to conduct these type of studies has its pros, it has its cons. Nothing is perfect, we know that. You just have to choose. Maybe it's a mixed method. Maybe you want to do a quick survey, and then you select a couple people to get more in-depth, knowledge. It will depend on what your goal is, and then you can decide what you want to do. And then, of course, there's the online survey. We all hate them. They are everywhere. Every 5 minutes, you get an ad on Facebook saying, take this quick survey for a chance to win $100. You never win the $100. It takes away from your time. So it's just, and you can't ask these follow-up questions, but it is faster. You can get to a wider audience. It's less expensive because it's usually just creating a survey, putting it on the platform, sending it out, right? So the other thing you have to deal with is lower response rate. Like we just said, no one has time to take away from their time to answer your survey. Again, it's very important to analyze what is your goal, and then you pick your tools. Cleaning your data, what does this mean? This is the part where the cleaning and the analyzing data is work with someone that knows how to do it. Cleaning data means taking out incomplete responses, taking out responses that don't make any sense, taking out people that answered they were 125 years old, just making sure that your data is thorough. But us communicators, we know a bit about, surveys, and we know a little bit about all of this, but it's better to engage from the beginning and a statistician with experience on these things so they can help you with not just cleaning the data, but analyzing the data. Running logistical regressions, running chi-squares, all of those beautiful mathematical terms that most of us are like, what is that? So make sure that you get on your team someone that can help you with this data, and they can help you extract what you want to extract from, whether it is qualitative, whether it is quantitative, what is it? And also, you're going to need to present all of this, how you're going to be collecting, cleaning, and analyzing to your review board. So you have to have this figured out before you go out there and start collecting responses. Otherwise, you're not going to have a thorough process. So the next is how. So one is you figure out the how. You've gone out and done it. You've gone through your whole review process. There we go. What do you do with it? Well, first is, the other day I saw this, that it is the responsibility of the person that is communicating for the one being communicated to understand the message. It's not their responsibility to understand the message. It's our responsibility to do it in a way that they understand what we're saying. So when you report your data, make sure that it's easily understood. It is useful for your target audience. So who is the target audience of this study? Is it your Minister of Health? If it is, then maybe a 5-slide presentation will be better than a whole report. They probably don't have the time to read the report. Is it your stakeholders? Depending on your audience, and I think that's what we do best as communicators, is who's our audience, how we can get to them, what are our tools, and make sure that when you're creating your report, that is one of the things that you think about. How am I gonna report this beautiful, awesome data I just gather on all of these behavioral and social drivers of vaccination and immunization. The next steps is to use your finding to design interventions. So what I really like about the BEST, and I'll talk about it later, is depending on the findings that you found in your survey, they already have in this guide some interventions that are proven to have worked to address the different issues that you found. So for example, if it's thinking and feeling, maybe an educational campaign on the side effects of the vaccine, or maybe interpersonal dialogues, go to the community, talk to them. If it's, I'll talk about that in a minute. Every single one of the constructs, so whether it is thinking and feeling, whether it is social processes or practical issues, there is already literature in the field and evidence that says these are some of the things that you can do to tackle these problems, or not problems, really, issues. And based on that, you can develop your intervention plan. The guide, oh my God, I keep doing this, sorry. Okay, the guide includes indicators for monitoring and evaluating your outcomes. And it's also very important to continue to monitor, if possible, in some way, what you've been doing. So this data collection, it takes time, it takes resources, I know, but it's good to know that if what we're doing is working. And if it's not working, how can we do it different, or how can we do it, or what can we do to address the things that are not working? It also helps us track trends over time, what's happening with vaccine hesitancy. There used to be a variety of platforms that were tracking hesitancy for COVID-19 vaccines. I'm sure you've seen them. The RCC Network had one, WHO had one called EARS, the Johns Hopkins University had one. The problem with all of them is that they're getting shut down. They're no longer gonna be happening or being used after, I believe it was August 2022. So they're all outdated. It's an incredible effort to get all this data. So it's up to us, I guess, at the local level to track some of this data, whether it is through social listening, whether it is through these formal services, whether it is through rapid surveys that we throw out in the community, whether it is through constantly having little focus groups of people here and there. We have to make sure that we know what's happening in the ground. Otherwise, how can we do anything, right? How do we know that what we're doing is working? How do we know that we need to improve? How do we know the new rumors that are coming in? We can't. And again, continue monitoring this, and it's also important to evaluate the impact of our interventions. So if we do a survey now, and then we do a whole strategy on things, it's probably a good idea at the end to see if anything had happened, to show that what we did had any impact. And these are the interventions. Like I said, this is all on the guide as well. You'll be able to see it. But so thinking and feeling and motivation. So thinking and feeling is related to what people are thinking about the vaccine. And here comes issues on vaccine safety, issues on risk perception, issues on, it's basically like what us as individuals are thinking and feeling about this process. The social processes, well, all of those are the influences from outside that are coming into us to influence our decision. So this could be religious issues, cultural issues, what my family and friends are doing, what the politicians around me are saying, what my healthcare provider is saying, all of that. So as you can see here, for thinking and feeling, you can run communication campaigns. These right here are examples. I'm not going to show you all of them because otherwise we'd be here till tomorrow, but you can go into the guide and see specifically all of these are different studies and examples of things that have worked in the field and things that have been done, of course, in different contexts. And you have to, ponder, is this going to work for my country? Or is there some things that I can tweak and then it will work? But information campaign, dialogue-based interventions, specifically one-on-one communication with the community. When it comes to social processes, community engagement, how do I go and talk to my community and get them to promote vaccination? We were just talking about this in the past. Social norm messaging, like how do we turn the norm from, and I don't want to call it anti-vaccine culture, but vaccine hesitant culture to a vaccine positive culture. Vaccine champions and advocates, we've used them in the past. We should probably keep using them. We want to move away from a political charged message or political actors as our spokespeople and use other members of our communities. And then, of course, the recommendation from healthcare workers. This is probably one of the most important ones. We know healthcare workers have become a bit more hesitant than we would like. So engaging healthcare workers, increasing their capacity, not just in immunization matter, but also in communication matters and how to communicate with the public will help us achieve this recommendation. We were just talking about this at lunch, but a lot of healthcare workers had never been part of the immunization program, had never had to deal with vaccinations. And think about cardiologists, think about oncologists. They've never had to think about vaccines. But then now, since they're the doctor in the family, their grandma, their sister, their cousin are coming to them asking, what do you think about the vaccines? So making sure that our healthcare workers across, not just doctors, not just nurses, community workers of all different specialties are aware of vaccination and how they work and what, how do they work? How are they developed? How do antigens work? All of that is important right here to make sure that they can make a recommendation. And these are more to address practical issues, right? Thankfully, in our region, vaccines are free. Most people don't have to pay them. I don't think this applies mostly to our region, but there are other regions in the world where you have to pay for your vaccine. Quality improvements. This is, I think, been done already, calling, families and saying, hey, your kid missed their vaccines, what's going on? On-site vaccination at work, home, and schools. Default appointments, incentives. The issue of incentives had become a bit of a subject during the COVID-19 vaccine. Should we pay people to get their vaccine? But that doesn't necessarily mean an incentive. It could be that as a worker, you get vaccinated today and then you get tomorrow off to, sleep away the fever and the aches. Or it could mean a bus ride, or it could mean, I don't know, some people were giving out, I'm not trying to promote alcohol, but some countries were giving out a free beer. Or in the US, you could go with your vaccine card and go eat free chicken wings. I don't know, things like that, right? Other types of incentives that we love to get free things. Who doesn't like free things? So those types of incentives. And of course, this is another more icky matter that it works. I wouldn't recommend this. This has to be very thoroughly thought out. Requirements are contentious. They're sensitive politically and, all the sensitivities that comes with that. But it's been shown to work, but this is something that you have to consider.